Hello, everybody. I'd like to welcome you. My name is Peter Finnemore. I am the Residency Program Director at Southside Hospital, OBGYN Residency Program. Uh, you are viewing this video because you've been invited for an interview with us, and we are very excited about that. I'm hoping over the next hour, you will get a sense of our program, a little bit of the background to our program, and an introduction to some of the other members of our program leadership. And we can't tell you how excited we are about this upcoming interview season and how different it is with the whole virtual concept. So we're hoping that this video with some slides gives you some insight onto what our program is like. So I am going to share my screen. And so we can kind of talk a little bit about some of um, the key components to our residency program. So the residency is based out of both Southside Hospital and Huntington Hospital. I am the residency program director. I'm also a urogynecologist. The associate program director is Dr. Ashley Shaliro. Our department chair is Dr. Ben Schwartz. Director of mentorship is Dr. Kristen Demertis, and our training program administrator is Kathy Barnes. I'm going to talk for a little bit now, and then we'll have Dr. Schwartz discuss some things with you as well. And then Dr. Demertis, you'll be able to hear from a little as well. So we do have some big news. We have a new name. And so as of just a few weeks ago, our name change was made official to South Shore University Hospital. We have not changed that with ACGME or with the NMRP or ERAS. We are continuing to use Southside for those programs just to try to decrease the confusion that might occur with a name change during an interview season. But we are very excited about the new name, but please, when you're going for your to do your rank list and things like that, it'll still come up as Southside Hospital. So I'm happy to finally share with you a picture of a full complement of residents. So we, as many of you may already know, we are I still call us a new program. This is the first year that we have a full complement of 16 residents. We started out in 2017 with the PGY4 class. They were our first group. Then we went to 8 residents. Then we went to 12, and this year we have 16. So we are very excited about the fact that we have a full complement. We are now able to cover all our services and all the 2 hospital locations. And it really feels great that that we've built something from the ground up, and we're very excited about that. We are extremely excited about the fact that all of our 4th-year residents matched in fellowship. Anna matched in pediatric adolescent gynecology, Anastasia in urogynecology, Zoe also in urogynecology, and Caitlin in GYN oncology. So this is quite an accomplishment, a real testament to their amazing hard work, the work of everybody in this program to make their educational goals come true, and we are so thrilled about this. And I don't think our fellowship match rate is going to remain at 100% forever. And so I know a couple of our 3rd years are also interested in fellowship, and so we are really excited about the trajectory and the success that we are having as a new program. So our program was fully accredited in 2018. So for many of you, I doubt you're really too familiar with how the process goes. But in 2017, in 2016 we submitted the application. We got approved, and in 2017 we were in the match. And then the RRC comes back a year later, and in 2018, they came back to make sure that everything we said we were doing, we actually were doing, or everything we wrote in the application, we were maintaining our promises. And so when they came in 2018, they gave us a full accreditation for 10 years. I suspect that they will at times during those 10 years kind of come back to us to make sure things are still going well. But for a brand new program to get full accreditation for 10 years is another wonderful accomplishment that we're all very proud of. As I said, we are 4 residents per year. We are part of the Zucker School of Medicine, and that has some perks with it as well, including access to the Zucker School of Medicine library, online library, with access to journals and textbooks and all sorts of really cool educational things. We also are site for the 3rd-year core rotation. So Zucker students do their core OBGYN rotation with us during the 3rd year. We also have quite a few sub-Is in the past who have rotated through our unit. For those of you who are familiar at all with healthcare in the Northeast, I'm sure you've heard of Northwell Health. It is a very large health system. There are currently 23 hospitals that are part of the Northwell Health System. And what the significance of this from a training perspective is that we have a tremendously large graduate medical education office. There are over 50 residency programs, over 80 ACGME fellowships, 20 independent clinical fellowships. So this graduate medical education for Northwell sort of oversees all of that, including us. It also gives our program access to some really pretty cool things as well, like a bioskills center where we do cadaver labs a couple times a year during orientation. As I mentioned, access to the Zucker library. We have very good relationships with some of the fellowship programs at nearby Northwell hospitals. Some of the fellows from those hospitals collaborate and do research with our residents. They're part of our didactics. We really have some strong relationships being part of such a large system, which is a real benefit when it comes to the training environment. The system itself is also very large, with over 70,000 employees. It is the largest private employer in the state. The only entity that employs more people in New York is the state of New York. So that also results in really excellent benefits. The employees of this hospital are taken care of very well by a system that is really a very large employer within the state. The tertiary hospitals within the Northwell Health System, in Nassau and Queens, it's North Shore LIJ. In New York City, it's Lenox Hill. In Staten Island, it's Staten Island University Hospital. And in Eastern Long Island, South Shore has been named the Tertiary Referral Center. So the implications of that, or why that's kind of important to you as a resident, has a lot to do with the fact that patients are being sort of brought into our hospital from the neighboring Northwell hospitals, that the complicated GYN oncology cases are done at South Shore. The complicated urogyn cases, the fistula repairs, things like that, we do them at South Shore. The OBGYN MFM high-risk patients are referred from our neighboring Eastern region hospitals and brought into the South Shore. So that lends itself to a really excellent training environment where you will see a diverse patient population. You will see a tremendous amount of pathology and different things that you might not really see in some of the smaller community hospitals and programs around the country. The other significance of this is the status of our NICU, and Dr. Schwartz will speak a little bit more directly to some of the upcoming renovations and changes to our campus. But suffice to say, we will be opening a level 3 NICU shortly, within the next several months. And as a result of that level 3 NICU, it will dramatically increase the antepartum MFM complexity of care that you will be involved with as a resident here. the current situation has some of these more complicated patients being sent to different regions within Northwell Health, and there is such a desperate need to have this tertiary level 3 NICU in the Eastern region, and we have been designated as such, and the system has really kind of committed to South Shore being that place, and that really is very exciting for us. It's also exploded the academic potential of our campus. We have now a new ED residency program that's in its second year. We are in the process of applying for a surgery residency. There's quite a sort of dramatic change towards a more academic campus, and we feel really pretty proud that we kind of started that when we began our residency program, and it's really just taken off. As I mentioned, you will be rotating through Huntington Hospital. That is a smaller community hospital that's about 15 miles north of South Shore. And Huntington has its own unique aspects, which we'll talk about in a minute, that make it really sort of rounds out your training. All the first year rotations and fourth year rotations are at South Shore Hospital. You spend 4 months during your second year and 2 months during the third year at Huntington. Our current continuity clinic is currently at Dolan Center, which is right a couple minutes outside of Huntington Hospital. But we've recognized the need to have a continuity clinic closer to Southside. And so we are in the final stages of negotiating with Sun River Health, which used to be Hudson River Health. That practice does about 725 deliveries at Southside. While those patients are in the hospital, they are taken care of primarily by the residents, and so we felt a very strong need to bridge that continuity and have our residents see those patients prenatally as well as postpartum. And so we are in the process and very close to finalizing the arrangements to have our continuity clinic as well closer to Bayshore. One of the exciting things personally for me was that in creating this program, in which I sort of wrote the application, which is about the size of an encyclopedia, a lot of the things that were put into it were things that I felt were kind of attractive as a resident. One of which was, that night float is really a pretty challenging rotation, and so what I felt was that it would be pretty cool if, as you go through residency, you do less and less nights. And so you do 3 months as a first year and a second year, 2 months as a third year, and only 1 month of nights as a fourth year. And I think that's really worked out well for us. I also thought it was really critical to have an ultrasound rotation very early on in your training. And so we've set up an ultrasound rotation during the first few months. During the first sort of third of your first year, you will spend a month in our antenatal testing unit, which is a rather large antenatal testing unit where the MFM doctors there do a tremendous number of consults, see a lot of patients. There's a lot of ultrasound that goes on there. And the idea is that you will be exposed to that during the beginning of your first year, either in July, August, September, October. One of those months you would spend in that unit and really become comfortable very early on in scanning and being able to do estimated fetal weights and fluid checks and biophysical profiles. And so that when you are on the unit on labor and delivery, really from the beginning, you know how to use an ultrasound machine and how to get the clinical information you need when you are on labor and delivery using the ultrasound unit, the ultrasound machine. I also felt it was really kind of important to be exposed to subspecialties early on. And so we have created our rotation such that as a second year, you will pretty much rotate in all the subspecialties. You do MFM, GYN-ONC, REI, Urogyn, and MIGS, minimally invasive GYN at Huntington. And so the idea being that, the earlier you are exposed to these subspecialties, the more you can kind of make a decision if this is something you want to subspecialize in as a fellow. It would sort of spark that interest, get you involved in research earlier on. And so that exposure earlier in your training, I think really bodes well for the decision-making about your career path and your career trajectory. The other component to that which I believe really pretty strongly, is that I think it's critical to have exposure to more complicated cases earlier in your training. And the fear that many of us have when we train residents is that if all of this sort of complex cases are kind of held until you are a third or fourth year, how comfortable will you get with those complicated cases? So it's been our one of our primary goals is to have our junior residents exposed to those complicated cases earlier on, with the idea that if they get exposed to them, they will just become more comfortable with them. And thus, when they graduate, they are really sort of very comfortable handling any kind of obstetric or gynecologic scenario. The minimally invasive GYN that's at Huntington is really rather unique. Huntington Hospital has several MIGS trained people who do quite a bit of minimally invasive benign gynecology, single site laparoscopic surgery, robotic surgery, straight stick laparoscopic. So the experience at Huntington affords our residents in their second and third years to really get comfortable with minimally invasive surgery. And that's something that's pretty unique to Huntington. And in the past, many residency programs and MIGS fellowships would sort of send their trainees to Huntington Hospital to work with these minimally invasive specialists. And since we've started our program, we're kind of phasing that out so that it's really the experience of our residents to learn from and participate in the surgeries with these highly advanced minimally invasive gynecologic surgeons. Another component to the design of the program was to create an elective during the third year. I was really very fortunate as a third-year resident to spend a month in Africa as my elective, which was a really unique, amazing global health opportunity that I've never forgotten. It also happened to be that I worked with several urogynecologists from a program that I was interested in going to. So I also got to kind of show them what I was all about. So it kind of really was an amazing experience for me. We look at it as either sort of a global health opportunity or as a way to kind of get your foot in the door in a fellowship if you are interested in fellowship. Many of our, as I said, the fourth years all matched. They did elective rotations at places which have helped them to get into fellowship. But we have a third year this year who's going to do his elective in an outpatient setting in an office. He wants to be a general OBGYN, and so this would be an experience for him to learn a little bit more about billing and coding and outpatient OBGYN. And so we really view that elective as wide open for whatever you may have an interest in doing. And that might even include a month of research if you feel like that would help your application for a fellowship or something that you're interested in. I mentioned the global health opportunities as an elective, but Northwell, another sort of perk about being part of such a large health system is they have really pretty unique global health opportunities. They've set up an OBGYN office in Guyana. And before the pandemic hit, the plan was that residents would sort of be rotating at that outpatient office in Guyana as part of a global health experience. Obviously, with the pandemic, that sort of slowed down, but our expectation is that will once again allow for you all to be given the opportunity to spend some time in a global health to see how healthcare is in a third world country and a really kind of unique, amazing experience. One of our attendings goes to Africa every year. Last year, before the pandemic, we sent 2 of our residents to Africa with him. So we do, as program leadership, we do value those kinds of opportunities and think they're really sort of once in a lifetime experiences. As a fourth year, you are sort of the chief of every service that you're on. And our idea about this is, again, that the fourth year resident is kind of functioning almost as a junior attending, with the notion of, if there's a C-section the fourth year will take the first year through that C-section, with the attending sort of obviously present scrub standing right by. But we're hoping that, and it's already really sort of bearing out the way we'd hoped, that our fourth years really kind of are the sort of attendings on the service as the chief. And so we feel very good that they're all going to step out after they graduate and be very comfortable with their training. And as a result of that, it's sort of a benefit to the junior residents to be able to learn directly from their senior residents, with obviously the attendings there as always. And we're excited about that as well. I mentioned the annual academic day for the health system as a way to kind of remind me to talk a little bit about research. There is a research requirement for every resident to do a research project. We also have a requirement to do a quality improvement project. We have a residency coordinator as part of our program, and we have been really kind of amazed at how our scholarly activity and how our residents have embraced the research. Dr. Demertzis, amongst other roles as the Director of Mentorship, she's been heavily involved in helping with research projects. Our residents have presented at national meetings, posters. They're in the process of writing manuscripts. We've been awarded they've been awarded sort of for some of these competitions first place, and we feel very strongly about that component to our program. And as I said earlier, we kind of we collaborate with other departments within Northwell Health and some of the fellowship programs, and with the whole idea that we're kind of a big team, and that really does wonders for promoting research within our campus. This is a kind of a general block diagram of the 4 years. I will point out that when I originally made this block diagram, it looks quite different from what it looks like now. And the reason for that is because we've been very sort of open to change. I can't sit here and tell you, well, this is the way it's been for the last 15, 20 years, because we are a new program. And so we feel very comfortable making changes as a result of the input of our residents. And we've taken that input to heart, and we seek it in applicants, that our applicants are sort of, knowing that they are going to be having some impact on the future people who come after them within the program. And so we engage our residents. We want them to contribute to the program, and we want them to give us insight as to what things are working, what things may be changed. And we've reacted very quickly to those things. And I think that's as a result of that, our residents feel very engaged and empowered that they have such a big impact on our program. As I mentioned, the first 4 months, so July, August, September, October, one of you will be doing the ultrasound rotation. The sort of next third, we will spend time in an outpatient office with family medicine and in the emergency department in fast track, with the idea that this will give you some exposure to primary care, which is something very much needed as an obstetrician gynecologist. And then the final third is in the SICU, which raises the level of complexity of care that you will experience seeing patients on vents, septic patients, much more complicated clinical scenarios, which I think kind of pushes the door open to when you start to do oncology and MFM as a second year. The other rotations as a first year are 3 months of nights, as we said, 3 months of GYN and 3 months of OB. On this block diagram, I would also point out again that the second year is a lot of subspecialty exposure: oncology, MFM, urogynecology, REI, Huntington, which is the minimally invasive exposure that you get. So that's all during PGY2. As a third year, in addition to the elective, we also have a breast rotation. We have a very busy breast surgeon and service at South Shore. And I think it's also kind of an important part of an OBGYN residency to get exposure to breast disease and to work with the breast surgeons to kind of know how to navigate that, because that's what you would be doing as part of your practice when you do graduate. And as we mentioned, the fourth year, you are the chief of every service. In terms of volume, between the two campuses, we do about 4,500 deliveries. As I mentioned, Southside gets a lot of referrals for high-risk OB. The MFM division is very, very busy. Dr. Schwartz is going to talk a little bit about the tremendous growth within that division, as well as across the entire campus. We do over 2,000 GYN cases. There is a surgery center, which is very close by. We are also in the start of a major renovation of a women and infant center, which I'm also going to let Dr. Schwartz kind of speak a little bit more to that directly. But we are very busy GYN service. There's GYN oncology is extremely busy. There's 3 urogyns, including myself, and we're a very busy service. The minimally invasive GYN, and as we talked about, general benign gynecology as well. Huntington Hospital and South Shore are both centers of excellence of minimally invasive surgery, as well as now, I believe, both are centers of excellence for robotic surgery. We do pat ourselves on the back a little bit, as South Shore was the first hospital within the Northwell Health System to become a center of excellence for robotic surgery. And I will say that was largely because of the volume of robotic surgery that Dr. Schwartz and myself did when we applied for that certification. Since then, all of the hospitals at Northwell have become centers of excellence, and the system has become a system of excellence. But we feel pretty proud that we were actually the first ones to do that at Southside, and know how quickly it kind of took over within the system. I just have the slide up about the women and infants expansion, but I'm not going to spend too much time on this because I think Dr. Schwartz is going to talk a little bit more about that. So I will let him do that as well. But we are very, very excited about this expansion, which is already underway. And by the time you all get here, it will be well on its way with different phases of it already open. This is the front entrance of South Shore. That is the Women and Infants Center, which is going to get renovated right kind of to the right, what you see. We have a brand new lobby that's opened. This is kind of an overhead view of that. To the right is that Women and Infant Center. To the left, you can see all the way over there, the heliport. And this campus has expanded so rapidly over the last few years. What's not in this picture, which I think is in Dr. Schwartz's pictures, is a brand new parking garage that opened just about a month ago, 1,000 spots. So we are no longer struggling for parking, which has been such a great relief to us, and also really a nice addition to our campus. We have a new emergency room department that opened about 2 years ago. We also have a new emergency room residency program that is in its second year. This is just some quick pictures about the lobby entrance, new labor and delivery, how the new labor rooms are going to look. And this is a picture of the front of Huntington Hospital. And so again, we are really kind of very excited about all of the changes that are ongoing. I would sort of hope that many of you will kind of see how exciting it is for us. When you get a chance to sort of speak directly to the residents, that's your best kind of gauge about the experience that they're going through and the training that they've had. So if I can, I would like to kind of let Dr. Schwartz speak at this point. I know he has a couple of slides, and as I said, he'll kind of go over some of that, but this is Dr. Ben Schwartz. He's the chairman of our department. He is a GYN oncologist. He's a senior vice president for Northwell Health in the Eastern region, and he's really been a tremendous asset to our program and to me personally. And I'll let you take it away, Ben.
Great, Pete. That's just a terrific job. Great introduction. Thank you for that. First, let me just say hello to everybody. These are different times for us. Doing this virtually and not in person is something that we're all kind of getting used to. I hope on behalf of our entire team and family here that all of your families are safe and healthy, and that your education has not had too many interruptions along the way. I am excited to have an opportunity to speak to you. I think I would be remiss if I didn't say congratulations to each of you. It's so impressive, your applications, and it's an incredibly competitive time now for OBGYN. Our program, we're proud to say, has been inundated with applications, and the fact that each of you have been invited to be a part of this process puts you in our very elite group of candidates. And we just, I'm certain that all of you will do great in the match. I'll take a few minutes to try to explain to you why I think we're spectacular, but I know that you're all going to do terrific. I'm going to try, if I can, to share my screen. Let's see how I do with this. Hold on. Okay, Pete, can you see that okay?
Yes.
Great. So I just wanted to give everybody a bit of an overview of what's happening in Northwell Health and in our area, and the relevance of our residency program in our department. So in terms of the bigger picture, I think Pete did a terrific job at sort of explaining the enormity of Northwell Health. And our obstetrical programs across the system are major and not just of a very high quality, but also of a high quantity. We deliver over 38,000 babies each year, which is approximately 1% of the American population every year, about close to 20% of the population of the New York State. So these are large programs, and as our health system grows, and for those of you who have been around healthcare enough to know, probably over time, healthcare will evolve in the United States into large regional health systems. That is part of our strategy. And we are aware that as you get bigger, it becomes much, much harder to be effective and competitive in local markets. Our health system was born of two hospitals in Nassau County. That's North Shore University Hospital and Long Island Jewish Medical Center. But as the system got bigger and bigger, I think the leadership started to appreciate that it was harder and harder to run competitive programs as those programs got further and further away from the home base. And so we divided the health system into three major regions: East, Central, and West. The Central region is around Eastern Queens and Nassau County. The Western region is Northern Westchester, Manhattan Island, and Staten Island. And the Eastern region you see depicted in this map here starts at Glen Cove Hospital in the upper left-hand corner of the picture, down to the Massapequa area and out to Montauk Point. The cluster of dots on the South Shore, and Pete, I don't know if you can see my pointer or not, but in the
We can.
Okay, great. So in this area on the South Shore, the Bayshore area, is where South Shore University Hospital sits. And on the North Shore of Suffolk County is where Huntington Hospital sits. And there are other hospitals scattered across the Eastern region, of which we also have strong OBGYN presences at. But the idea is that the Eastern region is basically almost a health system in and unto itself. The population of the area that you see here is over 2 million people. If you take just the Eastern region, our overall budget is in the billions of dollars, larger than 99% of most health systems. And we needed, as part of our clinical care model, an academic tertiary level care hospital to be the safety net and the referral destination for our sister hospitals in the region. And so South Shore University Hospital in Bayshore has been tapped to take on that role. And the other venue where the residents get their training is in Huntington Hospital, which has a very, very strong expertise in minimally invasive gynecological surgery, but also has a highly successful cadre of general OBGYNs that practice in that community. And so the experience of the residents in the two campuses is different. And we think it makes for a more well-rounded training experience. Now, South Shore University Hospital just changed its names. You'll see on my slides, it still says Southside Hospital because the ink is still not dried on the new name. In fact, what is now a university hospital was for decades a small community hospital. And as a result of that, many changes had to happen in the building, both in terms of the clinical care model, which I'm going to explain a little bit, as well as some of the construction that we're doing, which you've heard a little bit about, and I'm going to tell you a little bit more about. But we basically started from scratch, and over the last 5 years have built what I think is a really terrific program. Here you see these arrows demonstrate the distances from the different hospitals. We have a very sophisticated EMS and helicopter system. And the idea is that all of our pregnant patients or gynecological patients that are too complex for the other hospitals will be brought into our facility for care. Now, we're very proud, not just in our new residency program, but also in the fact that when all of these community, largely private practice-based departments had to undergo a transformation, the OBGYN department led the way in that transition and transformation. We have, I would say we're in about the middle of the 8th inning, to use a baseball analogy, in terms of getting to the place where we can say that we're full thickness, and I'll describe some of the gaps to you in a moment. We're particularly proud of our division of maternal fetal medicine. We've just added our fifth MFM specialist in Dr. Muscat, and we've just submitted, after approval of Northwell's GME office, an application to the ACGME for a new MFM fellowship, where we hope to have the first fellow outside of the match as soon as next July, when you folks would be starting as interns. We've gone from a division of GYN oncology of 1 to now we're hiring our 3rd. And we created a non-accredited advanced pelvic surgery fellowship where that fellow does complex cases, not just in the 2 hospitals that are part of the residency, but other hospitals as well. And for our residents and for those candidates that are concerned that the fellow could potentially dilute the surgical experience of the residents in training, I would argue nothing could be farther from the truth. Our fellow has been historically and is currently tremendous, and been a terrific asset for the residents to help them with their surgical training and to develop the expertise in taking care of more complicated patients, not just in the operating room, but around their care. As Pete described, as our leader of urogynecology, we have a terrific division of urogynecology. We are hiring a 2nd reproductive endocrinologist. We probably should be a group of 4. That's a gap we are slowly building into. We have a new division of OBGYN hospitalists. Dr. Shaliro, the program associate director, leads that front. And we are recently hired Dr. Bridget McHugh from the Oxnard Clinic in New Orleans, where she's presently the director of all laborist medicine. She'll be joining us as well. And we created a new non-accredited hospitalist, OBGYN hospitalist fellowship that our first fellow is now on the labor floor as part of that experience. It's a 1-year experience. We have some terrific talent in the MIGS space, particularly at Huntington Hospital. And we have a new MIGS doctor who's the chair at Mather Hospital, one of our sister hospitals in the region. And we've just submitted the application for our own MIGS fellowship, which will largely be home at Huntington Hospital, but the fellows will also come to South Shore and to Mather. I'm currently interviewing for a new family planning physician. That is also a gap right now that we have some great candidates for and expect to have filled by the time you folks come and start in July. And I think one of our really proudest accomplishments is that our medical school at Hofstra University at the Zucker School of Medicine is a relatively new school. It has a fascinating curriculum, and the way that the students are taught a little bit different than some of us old timers and the way that we went to school. Those students do their core rotations in OBGYN at several venues. And we were recently visited by our dean to let us know that not only were we the highest ranked OBGYN experience for third-year students at the School of Medicine across all of the campuses, but also across all other specialties. And I think that's for us, as what was once a community hospital and now growing into a university hospital, a strong testament to our attendings, to our nurses, but in particular to our residents, because the students mostly interact with our residents. This picture shows the current residents. We are beaming with pride in their successes, their research projects. As someone who's had an opportunity to work with many residencies over the course of my career, our residents are second to none. They have had unbelievably spectacular accomplishments. We did not really set out to compel people to go into fellowships. It was certainly interesting to find out that all 4 of our chiefs wanted to be fellows next year. And the fact that we matched so strongly with their top choices, I think, is really a spectacular accomplishment for them. And we're so proud of everything that they've done. And I think you'll hear a bit from Dr. Demertzis about kind of the interesting way that we've developed a space for trainees to grow and learn and be productive while finding good wellness balance. And I'll defer those comments to Kristen. Dr. Shaliro is a spectacular leader for our department. She's not just a great clinician and is a regular face on the labor floor as one of our OBGYN hospitalists, but she's really brought a terrific added component to Pete's leadership. If you were in my office during this process and not virtual, you'd see me blushing when I say that when you're a chairman of a department, you make some good decisions and you make some bad decisions. And the decision that I am the most proud of is in selecting Dr. Finnemore and Dr. Shaliro as the leaders of our program. At some point, I think I promised them that it wouldn't be a lot of work. I think that was just an outright lie. But the truth is that they have been so vested in the success of the residents. They have been such great champions for them. They have been such terrific listeners and have been, Pete sort of underscored this, but I'd like to say it again. The blocks and the rotations and which physicians residents work with most has gone through an amazing evolution over the last several years, because we are not a program that rests on the high ground of its tradition. We are brand new, and we see our residents as our customers, and we want to have very high customer satisfaction. So from my perspective, it's a terrific opportunity. We've by way of full disclosure, we have put a real emphasis on surgical volume and surgical expertise. The chairman is a GYN oncologist and the program director is a urogynecologist. And so we have a real concern that it's possible that physicians in your generation may go through training programs where surgical expertise is not the emphasis. We, prior to starting the residency, had residents visit from other programs, and it was glaring to us that while the residents were bright and hardworking, they really lacked the right basic abilities in the operating room. And so even for those of you who are not interested in doing fellowship, and we certainly hope there are many that won't do fellowship because we want to be training as many general OBGYNs as subspecialists, we still think it's important for you to have the right surgical expertise when you finish your training, and that is a real emphasis for us. Now, with every great clinical care model, you need the facilities to provide that care. This is a snapshot from my iPhone from Tuesday, literally a few days ago. Today's Friday, for those of you who are seeing this video after the fact. And early this week, we announced a $71 million investment in what we're calling the Women's and Infants Center. And I'll show you some pictures from that, but all private suites, doubling the operating room space on labor and delivery, adding more labor and delivery rooms, particularly with emphasis on building both rooms that are capable of taking care of intensive care unit level patients, but also some rooms designed to accommodate more holistic approach to birthing. Both are important emphases for us. We're building a brand new state-of-the-art NICU. I'll show you pictures in a minute. And we are doing this not only to bolster the OBGYN platform for us at this hospital, but also as part of nearly $500 million investment in brand new facilities at the hospital. The picture is a little small. I apologize for that. But if you can see the picture on this slide, there's a sort of red brick building in the middle with a gray flat top. To the right is Women's and Infants. And to the left is a white brand new building that does not exist yet, which will basically double the size of the hospital and is expected to be completed within the next 3 years. We fully expect when we give you your new white coats that we'll also have to be giving you a hard hat as well, because there's going to be some construction going on around you. And we apologize for that, but by the time you finish your training, the facilities are going to be absolutely spectacular. Here's a few pictures. Pete already showed you the new entrance to labor and delivery. The existing main lobby of the hospital will be replaced by a new lobby in the new pavilion that's being built. And so the existing main lobby of the hospital, which was recently renovated, will be a dedicated lobby just for women's and infants. Labor and delivery will be getting a completely new facelift with state-of-the-art technology built into the systems there. All of the labor rooms will be either refurbished in addition to the new rooms that will be built. The NICU, in New York State, NICU code requires that you build NICU rooms and NICU spaces to the same size as you would for an adult. So for a tiny newborn, the spaces are going to be quite large and comfortable. For those of you who saw the map, we're on the South Shore of Long Island. There's a lot of sort of beach and ocean themes to the color and lighting patterns that go into the architecture of the spaces. And everything is very wide open with a lot of glass and a lot of light that makes it, from a logistical standpoint, feasible for our care providers to see what's going on in multiple rooms at once. But again, a newborn baby will have a large room, including living space for families to live in with their NICU baby to help participate in the baby's care and to help with bonding. We'll have 29 private suites on postpartum, including private showers, with state-of-the-art medical technology hidden and built into some of the fixtures on the walls and lighting behind the structures. And so, obviously you can hear our enthusiasm. I could probably go on and on. I'll leave you with my email address here, which is bschwartz1@northwell.edu, with the hope and expectation that each of you will reach out at some point if you have any questions or concerns. Now, Pete, please don't laugh at me, but I will also do what I've done every year, which is to say to you that I am absolutely convinced that one of you out there is a mole. And people laugh at me when I say that, but I want to explain what I mean because I think it's important by way of expectation setting. What do I mean by a mole? We as a program are very dedicated to being 100% compliant with every rule of the ACGME and every rule of the match. We take the number of hours that you work very seriously. We take any concerns that anyone has regarding rotations and the value of them very seriously. And we also believe, notwithstanding what may happen in other venues, in our program, we take the match extremely seriously. And as a consequence of that, what frequently happens is candidates will send us emails or letters that are extremely kind and express sincere interest in our program. And we're absolutely convinced that one of you out there is getting paid by the ACGME to send us a nice email with the hope that you'll catch us at responding by saying something completely inappropriate. So for the record, if you email me, and I'm giving you my email address, you should not feel obligated to, but if you were to, and my response typically will be, thank you for your email. It was very nice to meet you. Good luck in the match. And it doesn't mean, if that seems abrupt or short or with some sort of lack of enthusiasm, that we don't love you and are dying to hear that you want to come to us. It means that we're going to be extremely professional in how we communicate with the candidates and respect the sanctity of the match process so that it protects you and protects us. And so that we don't have to worry about that. So please don't take what might seem like an abrupt or short response from us as an indication of good or negative with regards to how much we're excited to hear that you might want to come and join us. Pete, so with closing, please don't be the mole. And with that, pass it back to Dr. Finnemore. Good luck, everybody.
Thank you very much, Ben. I really appreciate it. Without further ado, I am going to introduce Dr. Kristen DeMertzis. As I mentioned, she has the title of Director of Resident Mentorship, but her role in our program is much more than that. There really is no title that would sort of encompass everything she does, and it's quite unique. And so I will give her some time to explain to you all her role. It's something that we're very proud of. And thank you, Kristen. And I will mute so you can take over.
All righty. Well, hello and a virtual welcome to South Shore University Hospital. My name is Kristen DeMertzis, and we're so excited to get to know you a bit through this interview process. As Dr. Finnemore mentioned, I'm going to discuss my role in the residency program because it really is unique. We have made a very concerted effort to weave my role into the leadership of our department and of the program, and it's something we're very proud to offer to our residents and the department at large. I am a clinical neuropsychologist, and as Dr. Finnemore mentioned, my title in the program is Director of Resident Mentorship for the OBGYN residency at South Shore University Hospital and Huntington Hospital. And in this role, I heavily collaborate with Dr. Finnemore, Dr. Sholiro, and our residents on program development efforts. I facilitate professional development and wellness of our residents during their 4 years with us, and I'm going to talk about that a bit more. I'm part of the Residency Clinical Competency Committee and Program Evaluation Committee. I coordinate faculty development efforts, and I participate in departmental quality endeavors such as our ethics committee, integrative medicine initiatives, case and simulation drill debriefs, and quality improvement and research projects of our residents and faculty. So with respect to my role in residents' professional development and wellness, we firmly believe that despite these years of residency being incredibly challenging in a multitude of ways, there are many things that can help navigate these years in a way that residents stay true to who they really want to be professionally and the way they hope to continue to develop themselves professionally. And it's done in a manner that's sustainable because they're also learning how to balance that with caring for themselves, having work-life balance. And it really, we believe, unlocks the professional potential each resident has so that they can continue on to their desired career path, whatever that looks like. The ways in which I interact with residents are multiple. So every month during the residents' protected didactic time, I facilitate modules of a curriculum Dr. Finnemore and I developed called PAWS, or Professionalism and Wellness Skills. And in this curriculum, we cover evidence-based wellness strategies such as cognitive restructuring, emotional regulation, behavioral modification. We touch upon leadership qualities such as effective communication skills, emotional intelligence, managing challenging patient and collegial interactions, humanism in medicine, diversity and inclusion, social determinants of health, sleep hygiene and fatigue mitigation, financial management principles during residency and the beyond, and a variety of other topics. And this curriculum involves coordination with leaders within our health system who possess certain expertise in particular areas. So they join us for those sessions. And I'm a heavy believer that professionalism and wellness go hand in hand. So that if we help strengthen aspects of professionalism, such as your communication skills, your connection with the purpose of your work, principles of what a high performing team looks like, that this contributes to a sense of wellness in residents. And similarly, if we focus on how to care for your own needs mentally, physically, emotionally during these years, it puts you in the best place to be your best self at work and to really allow your professional strengths to shine and be bolstered over time. In addition to the monthly meetings, each PGY level has a process group with me, and this is a really wonderful way to connect with one another within a class, to connect with me. This is great when interns are coming in, they're acclimating to residency, they're feeling all of the normal stressors that interns feel, and they may not be seeing one another on rotation. So it's a wonderful way to really bond that class from the very beginning. And we cover a lot of territory in the group meetings. So we touch upon how each person's doing from a wellness perspective, from a professional goals perspective. We talk about program improvement issues that sometimes result in full program leadership meetings and possibly changes to rotations or didactics or other things in the program, faculty development efforts and the like. And we'll go all the way through chief year where you're acclimating to that leadership role and the next steps beyond residency. I also meet individually on an as needed basis with residents. So they reach out to me. I also reach out to them depending on what's going on. And I really try to make myself as available as possible given the constraints with OR schedules and night floats and other things going on, sign out, so that we can meet in person or by phone or in a virtual meeting and discuss relevant issues going on at the moment. I coordinate the faculty mentorship program. So a few months before our new cohort of interns starts, I reach out to each intern and I get a sense of whether there are particular aspects you would like in a mentor with respect to having a mentor who's a generalist or in a certain subspecialty, having a mentor of color, having a mentor who's involved with global health. And I'll try to match folks up depending on preferences as best I can. And of course, you're going to add to this cadre of mentors as you continue along in the program, but we love the idea of somebody reaching out to you in addition to us to welcome you to the program and to also be a point person who's going to check in on you, who you can bounce things off of, talk about professional goals, struggles, challenges in residency, celebrate the great times and all of that. I'm also heavily involved in this year. It was fellowship prep. In the future, because everybody chose to pursue fellowship in the future, I assume it's also going to be job prep following residency. So to that end, I work on CVs with the residents, their personal statements and applications. Dr. Finnemore and I have modified a fellowship prep curriculum that was developed in the Department of Medicine. And this involves general principles of fellowship or job interviewing. And it also involves mock interviews with faculty where each resident gets extensive feedback about the interviews. And we work on those things so that you feel the most prepped you can for the experience and the most comfortable. And if it was for job interviews, we're also going to include pertinent issues such as contract negotiations and other aspects there. I help when there are educational or learning needs, such as some folks want structured CREOG study plans. So I help just coordinate with faculty who can be a point person for that so people can have some accountability and structure to their study, particularly if they're struggling with that area. Sometimes facilitating rotation meetings in the subspecialties or with the OB service, et cetera. And many other functions, I guess, along those lines. So Dr. Finnemore's point, it's difficult to kind of go into all those specifics, but hopefully you got a snapshot of what my role is in the program, in the department. And for those of you who end up matching with us, We really look forward to partnering with you on this incredibly exciting journey. If you're not meeting with me for a one-to-one interview and you have any questions about my role, Kathy Barnes will supply our information. Please feel very free to reach out to me. And I wish you all the best of luck in this process.
Thank you, Kristen. It's really true. It's hard to in 15 minutes kind of give an idea to everybody what you do. So that was great. And I think, the best thing again would be, when you are interviewing, when you have that chance to kind of talk with the residents, you can really get a firsthand account of how interactive they are with all of us. But especially Kristen, in terms of some of those components to training that are a little bit more challenging and require a little bit more thought outside of the technical and surgical and medical knowledge that we're also responsible for teaching you. So I would just like to wrap up by saying, once again, thank you. We are very excited to meet with you all. We really look forward to trying to get to know you a little through this virtual platform. But we hope that you will have plenty of opportunity to ask any additional questions. We hope that this was a little bit of an informative to you to get a sense of what our program is like. And we thank you for the time, and please feel free to reach out to us after the interviews, during the interviews, when you're sort of finalizing your rank list. We really want to be available to be able to kind of answer any questions or to give you any sense of some of the things that you may need clarification on. So we wish you the best of luck and look forward to spending some time together during the interview process. Thank you. Bye now.
Take care.